I do not take it for granted. So I'm very, very thankful to all my teachers and mentors in IPC, including Professor Gunshola, um, and for the great work she did in molding most of us in this discipline, and also our very, very good leader at the NCDC, Dr. Tochio Kwon, who is also pushing this agenda forward in the country. I want to also thank my colleagues who have always been there to support, provide support, kind of supportive environment for all of us, and we continue to grow together in the practice. So I'm very, very grateful to the entire IPC family in Nigeria for being there for us. And I won't forget our mama, Shawande, for really making this NSIC project, up and running. She's always there for us, encouraging us to keep doing our work. Mama, thank you so much for being there. I won't take more time. I will just proceed to do the presentation. So the outline for this presentation is as shown on the screen there. We'll look at our learning objective, we'll take a brief introduction, go through the overview for 5 moments for hand hygiene, and then we'll look at the steps implementing a hand hygiene audit, and then we'll also consider those common challenges of implementation and the strategies for managing. Then we take our key takeaways, and then we conclude. So our objectives for this presentation are as follows. So by the end of the presentation, it's my expectation that all participants will be able to at least define the key terms related to hand hygiene audits, understand the why and when of 5 moments for hand hygiene, because that's basically the focus of our audit. We do a hand hygiene audit based on WHO's 5 moments for hand hygiene, and understand the role of hand hygiene audit in IPC. And of course, very key to our presentation is for us to be able to align these essential steps for planning and implementing a successful hand hygiene audit. And then, of course, to identify and manage common challenges encountered during audit implementation. So to still take us to what we are considering today, the crux of IPC is to address healthcare-associated infections, which is actually a serious public health issue in Nigeria. The burden is high in the country, as shown by several studies. One study indicates that the cumulative incidence of healthcare-associated infection in the country, especially in surgical wards, is as high as 45.8%. That is huge. And not only that, another report strongly suggests that about 900,000 Nigerians, experience a healthcare-associated infection within a year. We did a study recently in my facility, and we observed a 4% incidence of presumptive catheter-associated urinary tract infection among hospitalized patients. There's another study that strongly suggests that that the incidence of infections among pediatric surgical patients could be as high as 26.8%. So these statistics tells us that in Nigeria, that hand hygiene directly to reducing the risk of healthcare infection. However, hand hygiene compliance is still very, very poor. Elsewhere, they are making progress. Then in Nigeria, we have our national IPC program. Hand hygiene has been adopted as recommended by the WHO as the national IPC process indicator. So hand hygiene is very, very key. But unfortunately, we have not been measuring hand hygiene as recommended by the WHO and other bodies globally. So there's a need for us to accurately measure hand hygiene. And that is where the subject of today becomes key, because we are looking at hand hygiene audits. We need to start doing hand hygiene audits because it's still a challenge in most of our facilities. And you cannot improve what you don't measure. I've always made these statements whenever I have the privilege to make presentations like this. So for healthcare facilities in the countries, there's a need for us to have an established baseline, of hand hygiene compliance, so that we can track changes over time, whether we're improving or not improving. But if we can establish a baseline and we continue to, to track, to do audits, we'll be able to know if we are making progress or not. So looking at some of the key definitions in this presentation, hand hygiene, which refers to any action, whatever it is, of hand cleansing to remove visible soil or dirt, or killing of transient microorganisms, defines hand hygiene. It could be by using soap and running water, or alcohol-based hand rub, or use or for the surgeons, they do surgical hand scrubbing. And then there are other methods of hand cleansings, maybe using hand antiseptic hand wipes. Hand hygiene audit, a very simple definition here. We'll see a more technical definition as we progress in this presentation. It's a systematic quality improvement process of observing and recording hand hygiene practices to assess compliance with established protocols. Compliance rates is the percentage of observed hand hygiene opportunities where a correct hand hygiene action was taken. We would we'll define what hand hygiene opportunities as we progress. Then point of care is the place where three elements, that's the healthcare worker, the patient, and care activity, intersect, where the three come together. That is where we'll be observing hand hygiene. So it's key. So it's very important we understand this point of care concept. So let's go just take an overview of hand hygiene. I'll start with this time series graph from Johns Hopkins University. Now, if you look at this graph, I don't know whether it's very clear on your end there. It doesn't look very clear here. Oh, sorry. I think when I was saving it as a PDF, there was a shift. But if you look at the graph, you will notice that the black line represents the trend in MRSA transmission, while the red line indicates the trend in hand hygiene compliance. So you will notice that as hand hygiene compliance increase, the rate of transmission of MRSA decreases. So that is a graphical demonstration of the effect of hand hygiene. So when we improve our compliance with hand hygiene, then we expect that the rate of HAI, of course, MRSA is just one of them, should also decrease in our facility. But what is more important in this graph, which I want to point out, is if you look at the horizontal axis, that's the x-axis of this graph, you will see that this data was collected between January 2008 and November 2013. That's almost 4.5 years. And if you also notice, the data was collected every 3 months, that is quarterly: January, March, May, July, September, November. Now, the importance of this is that they were able to collect this data consistently and regularly. And we know that we need up to 10 or more data points for us to see a trend in this type of graph. Maybe this is a time series graph. So if we are going to venture into hand hygiene auditing, we should also be ready to collect this data regularly, so that when we plot the data points on the graph, we'll be able to see trends, whether it's progressively increasing or decreasing. That's what I really want to highlight here, because what we have observed over the years for facilities that carry out hand hygiene audits, maybe we'll do it once in a year. And if we do it once in a year, there is no way we can use that data and and say with some high level of confidence that we have made progress. Let me give an example. Assuming in your facility you carry out your audit maybe in this month of April, and you got a compliance rate of, say, let me say 25%, and you didn't do it again, and then you now repeat it again maybe next year about this time, and you now got maybe 30% or say 23%. Now you cannot say with confidence that if you got 30%, there was an improvement, or that if you got 23%, there was not an improvement. Why? Because you have just taken this data at 2 points in time. So you can't really use that data to define progress or no progress. I know that's not the subject of today's discussion, but I must mention here because we are IPC professionals. There's something that is known as common cause variation, and also we also have special cause variation. I don't know if I should go into that, but let's just know that naturally, if we are collecting data over time, there's going to be common cause variation. So you may have 25% this month, you may have 23% the other month, you may have 28% the other month, you may have 30%, 29. That may just be the normal variation, so no change. And then you may have this special cause that something led to it. Maybe there was an activity, there was a special intervention, and you may just see a sudden change. Your compliance rate will now jump, and you'll be rejoicing that, oh, I've experienced a change. That may not be the case. Something may just have caused that. And then maybe once that thing is taken off the way, you will now go back to where you were before. So it's important for us to establish that culture of collecting this data at least quarterly, so that by the time we are able to get up to 10 data points. Maybe we have collected the data for like maybe in a year we collect the data maybe 5 times or 4 times. Maybe by the time we have collected data for like 2 years, we'll be able to see a trend, whether we are improving or not improving. So I really have spent so much time on this, but it's important we highlight it, because if we must use our hand hygiene audit data to guide decisions about hand hygiene promotion, hand hygiene training, and education, then we must commit to collect this data regularly. We can do it every 2 months, we can do it every 3 months. So in brief, let's look at the 5 moments for hand hygiene. It's a common subject among IPC professionals. It's a concept that describes the moment when hand hygiene is required to effectively interrupt microbial transmission during care sequence. As we provide care, our hands come in contact with surfaces that may be contaminated. So these 5 moments have been defined, to help us identify those moments that if hand hygiene is performed, we will effectively interrupt microbial transmission. And then the 5 moments for hand hygiene should be performed at the point of care, because that is actually where we'll be observing hand hygiene practice, at the point of care, where you have the patients, the healthcare worker, you can see there, and the care activity. So that is exactly what this next slide is showing us. The point of care is very key in hand hygiene audit, and of course, the point of care is within the patient zone, which the patient zone has everything that is dedicated to that patient, that is exclusively for the use for that particular patient. While the healthcare zone is every other thing outside the patient zone, including other patients zone. This is a concept that we go in more detail if we're discussing hand hygiene as a key subject here. But we just want to quickly look at the moments for hand hygiene. So moment one is before patient contact. So we do this because we want to prevent the transmission of harmful organisms from the healthcare workers' hands to the patients. And we must do that before we touch a patient, even if we are going to wear gloves. Remember the WHO theme for this year is the focus is that glove. In fact, the focus is that gloves should not replace the need for hand hygiene. So before we conduct any physical examination, such as taking vital signs and etc., anything that will bring in contact with the patient, we must perform hand hygiene. The next moment two, is before aseptic procedure. And why do we do that? We want to prevent contamination of sterile or clean areas during procedures as we engage in healthcare activity. So before any task that might lead us to touch sterile areas or open body sites, we need to perform hand hygiene. When we are giving IV medications, we want to instill eye drops, we want to pass an NG tube, we want to take care of wound. These are aseptic procedures. We must perform hand hygiene before carrying them out. Moment three is after body fluid exposure risk. Why? The reason is we want to remove any harmful microorganisms from our hands that may have been exposed to body fluids. So immediately after any task that potentially exposes our hands to body fluids, whether it's blood, urine, or vomitus, whatever it is, we need to perform hand hygiene. Even if we don't see visible fluid on the hands, we need to perform hand hygiene because the concept here is potential exposure. Any such activity, after taking blood, after handling urine specimen, after dealing with respiratory secretion, anything that could potentially expose us to body fluid, we need to perform hygiene. Why we need to go through this 5 moments? Because it's important because the hand hygiene of observation will be based on this. So you must know the moments for hand hygiene before you start conducting hand hygiene audit. So moment four is after touching patient. Why? You want to prevent transferring pathogens from the patient to other surfaces, to other patients, or to other healthcare workers within that healthcare. So when do you do that? Immediately after patient contact. After you touch a patient's skin, maybe after performing a physical examination, you touch the patient clothing, bedding, or any personal item belonging to the patient, you have touched the patient. So you need to perform hand hygiene. Moment five, after contact with patient surrounding, why? We want to ensure that pathogens that might have been transferred to surfaces within the patient's environment are removed from our hands. So if we have big organisms from the patient's environment, we want to make sure that they are not in our hands. So after touching any object or surface in the patient's environment, even if the patient was not directly touched, after adjusting bed linens, after handling the patient's tray or equipment, after cleaning the patient's room, even after touching certain equipment that are used especially for that patient, it's assumed that you touch the patient surroundings. In that case, you need to perform hand hygiene. So how to perform hand hygiene? This is just an overview. You need about 20 to 30 seconds for hand rubbing with an alcohol-based sanitizer. It doesn't take long. The techniques, I'm sure many of us have been exposed to how to perform hand hygiene. Of course, when we are doing hand hygiene audit, the focus is not really on the technique per se, how the health worker was able to rub all the surfaces. We just want to ensure that the healthcare worker was able to perform hand hygiene when he or she needed to do so. Then if the quality of hand hygiene performance is effective, it forms the basis for further training on how to perform hand hygiene. And of course, when you're hand washing with soap and water, you do that for between 40 to 60 seconds. The truth of the matter is that if you have observed healthcare workers perform hand hygiene, you know that we don't stick to this time. We do it for less than 10 seconds most of the time, and we leave. And that's part of what we need to emphasize during our training and retraining of our healthcare workers. So key takeaways the overview of the 5 moments for hand hygiene is that the 5 moments for hand hygiene are key to preventing infections in healthcare settings. We must remember the why and the when of each moment to reduce cross-contamination and protect both patients and healthcare workers. Consistent hand hygiene is one of the simplest, like we said at the beginning, yet is the most effective ways to improve patient safety and reduce the transmission of healthcare-associated infections in our facilities. Let's make progress with the subject of today, which is hand hygiene audit. So what is it all about? We've been able to put together this simulation, which also reflects what we presented in the very first slides. The hand hygiene audit may be defined as a quality improvement process. That's the first thing we need to know, that is part of our quality improvement process. And what does this seek to do? To improve patient safety by determining healthcare workers' compliance with recommended guidelines for hand hygiene. And then we now use the results to guide decisions about hand hygiene promotion, education, and training. So we are not doing this audit just for the fun of it, or just to notify maybe NCDC that we have done it. No, the purpose is to use the result to inform decisions about um, improving hand hygiene in our facility. I hope that is well emphasized, because the truth is that most times, most facilities are just doing the hand hygiene audit now just to fulfill the demands from NCDC that it should be done. But that is not just the purpose. The purpose is to guide decisions about hand hygiene promotion, education, and training. And of course, the ultimate objective is for us to improve patient safety. So let's look at the steps in implementing the hand hygiene audit. Step one is planning. Let's say if you don't plan, you're actually planning to fail. So to carry out or implement the hand hygiene audit, we need to start first by planning. Well, I assume that the team is already in place. Talking about the IPC team, they're already in place. So the issue of mobilizing maybe an IPC, a multidisciplinary team again to come and see it is deliberately out of this. But that's an important first step. If you don't have a team, the team must be in place. So your IPC team will meet and begin to discuss the scope of the audits. You want to cover which area of the hospital, which group do you want to target? Now, when we talk about target group, most of the time it is based on what you have observed from previous audits. If you discover that doctors are not doing well, or physiotherapists are not doing well, or nurses are not doing well, you may want to decide to target that group and really know what is going on with that group. So that's part of the consideration when you are starting your audit. Then you determine the timelines of the audit activities. Are you going to do it in a week? Are you going to do it in 2 weeks or 3 weeks or 4 weeks? But ideally, I would recommend that we target to complete our audit activities in 2 weeks, so that we quickly uh, analyze our data and then share with the stakeholders. Then you need a budget for the audit process. It's not audit, hand hygiene audit is not an activity you just wake up one morning, pack your books, and then call your team together and to the ward to go and carry out the activity. You need to plan for it. You need to prepare a budget, because you will need to get the forms ready. You need to get erasers. You need to get pencils, and sometimes you need to provide maybe snacks for the auditors, because they will spend some time standing and observing the process, and they may conduct more than 3 sessions in a day. So you need to prepare for that. Then the service delivery areas, of course, for each audit, you must identify the service delivery areas you want to cover. You might say, okay, I'm going to cover the surgical wards, or the medical wards, or it just depends. You must determine that before the process. Then not only that, you need to communicate with the leadership of the service delivery areas. You need to communicate with those involved. It's part of the planning. We are sending that communication that, look, we are coming. We have identified your unit as an area where we conduct our audit. You may tell the person about the whole process, how it's going to be, and tell them the period you are going to likely conduct the activity. Then you procure the material you need for the audit. Remember we said all those tools, the hand hygiene observation forms, and sometimes the water infrastructure survey, they are all part of what may need to be in place before we implement the audit. Then, of course, okay, I mean that you must have identified your hand hygiene auditors, those who carry out the auditor. Sorry, I missed. I didn't mention that. You don't perform an audit without training your hand hygiene auditors. So when you're, in fact, before you start planning for the hand hygiene audit, you must have trained your hand hygiene auditors. Or if you don't have one, and it's the IPC team that will conduct the audit, then they must have been trained and validated. If you have trained your hand hygiene auditors already, and maybe you trained them maybe 3 months ago, and you want to do the audit today or within this week, then you must conduct a refresher training. That refresher training entails that you bring the auditors together, you go through the slides that you used to train them, so like the one we are using now, refresh them on the moments of hand hygiene, and possibly let them view the WHO hand hygiene video. Then you take them to the ward where they are going to do observation. Let them carry out this observation um, in real life healthcare activity. So when they do that, you are now sure that they understand what 5 moments for hygiene is, they understand what an opportunity is, they understand what an indication is, and they understand what a hand hygiene action is, and how to record those actions on the data collection tool. That is the form. So it's very, very key that our auditors do a refresher training before the actual audit activity. We have not been doing this. That's why I'm emphasizing we've not been doing it for facilities that have attempted to do it. Most times, it's only the IPC focal person and few others who are proficient already. They will go and do the exercise and report. So we need to adopt this approach to make sure we get accurate hand hygiene compliance data. So step 2 is the data collection process actually. So in this process, we need to visit the service delivery area for the audit. Hand hygiene audit is not something we perform in our offices. It's not a desktop activity. You cannot stay in your office and determine what the compliance rate is. And someone cannot inform you on phone that I saw this patient, he did not perform hand hygiene, please document it. So you go there physically, introduce yourself and the purpose of visit to whoever is in charge of that particular facility. Then you observe patient care activity unobtrusively. That you don't interfere, you don't interrupt activity, just observe, and then observe individual healthcare workers. If you are just starting, you can't observe multiple healthcare workers at the same time. So focus on a particular healthcare worker and observe the activity of that healthcare worker and document findings on the observation form immediately. If the healthcare activity, if the healthcare worker complied after a certain, if there was an opportunity and the right action was taken, document. If the right action was not taken, of course, you document as missed. Then you must respect patient privacy. Okay, before I must mention that anything you don't observe during an audit, please don't assume, don't record. I remember when we were watching the hand hygiene video. Initially, most of us we will assume what was the next action of the healthcare worker and we'll decide whether the person missed or not. That is not correct. So you must only document what you observed. Don't assume that I saw the healthcare worker was about to do this, so I assume that this is what could have happened. You don't assume. You document only what you observe, and then of course you need to respect privacy. Sometimes when you are making an observation, and for some reason the nurse or maybe the doctor decide to screen that patient, please that should mark the end of that session. You can't tell them to keep it open so that you can continue with your observation. You must respect that privacy. And then during medical emergencies and when you have patient in palliative care, it's good to avoid auditing during situations like that. There's this saying that when you're in an emergency, and hygiene is secondary to patient safety. It becomes a secondary issue. You want to make sure the patient is okay before you start counting whether moments were missed or not missed. Then the third step, which is the last, is the post data collection step, which maybe you have done the activity. You now have to regroup as a team and discuss what happened during the audit session. You want to know what went well and what did not go so well, and also to discuss lessons learned and how to improve subsequent subsequent sessions. And not only that, to also consider the data that was collected. As you will see, there are times when by just looking at the hand observation form, you will see that if you look at some of the grids, you will just see that something is not right with this data. And you ask more questions. And usually we encourage our auditors when they are going that if you observe any particular thing that you didn't understand, and you just use your pencil and make a small note so that you can discuss that with your colleague when you are having the debrief session. It's very, very important. So in such situation, maybe the IPC focal person who may be the most experienced in the team will now look at that scenario, that particular scenario, and then advise the team on on um, on what should be the best way forward, either to discard the data or accept the data, as the case may be. Then after that, you need to analyze the entire data set, and then you interpret the data. You want to interpret the data in terms of the uh, the number of the overall compliance, then the moments that were most complied with, the moments that were least complied with, then the healthcare worker group or the professional group that is doing better or doing worse. So these are the issues that will be considered during the analysis and interpretation. Now, once that is done, you make your recommendation based on the result of the audit and other contextual issues that may have arisen during your observation. I remember when in the general hospital in Abuja recently for this kind of exercise, we observed a lot of things and then we discussed that after the audit exercise. And it was a good learning process because there were some contextual issues that may not have been addressed during our training. So it was very good for us to learn during the debrief session. And then not only that, once you have prepared your reports, you need to share with all stakeholders. That includes the healthcare workers and the hospital leaders. And of course, in our country now, the NCDC is also a major stakeholder in this business. So when we carry out our audits, we are not just sharing with the healthcare workers in our facilities or our hospital leadership. We are also sharing that information with the Nigeria Center for Disease Control, the um, the IPC unit. So what are some common challenges encountered during hygiene audits? Now, this is based on um, experiences from different centers and also what has been established by research. We could have this issue of selection bias where there's systematic exclusion of certain healthcare workers. Remember, I mentioned that sometimes we may just decide to observe only doctors. Sometimes we decide to observe only nurses, you know, and then in the end, we will now have skewed data that is not representative of the behavior of healthcare workers in that particular hospital. So selection bias is a problem, and sometimes we might decide to carry out our observations only in the morning because that's the time that is most convenient for the hygiene auditors. Then we also have the Hawthorne effect, which we know the Hawthorne effect described the situation where a healthcare worker will alter his or her behavior because they know that someone is observing them. So they may decide to behave well because you are there. And when you leave that environment, they continue to do what they have been doing. So that's a challenge um, during hand hygiene audits. Then the issue of time and resource constraint. Of course, we know that hand hygiene audit is not, it's not one of those it's not one of those low hanging fruit. Hand hygiene audit is not a low hanging fruit as we keep saying, as we used to say. It's one of those fruit that is high up the tree. We must climb and bring it down. So time and resource constraint is a problem. We don't expect the IPC focal persons to do everything. Sometimes they are also saddled with other responsibilities in the hospital. And then not only that, our hand hygiene auditors from experience from other facilities, when you train them, before you know it, if they are nurses, they are moved to other units. And when you need them to carry out the audit, they are not there to tell you that look, we are quite busy. So it's a big issue, which I believe that as we make progress in our IPC journey in the country, we will overcome. And we also know that most of us who are IPC focal persons or IPC nurses, our we do it on ad hoc basis. We also have primary responsibilities in the hospital, and so we sometimes we don't have all the time to be fully engaged in IPC work. So it's a very serious concern. Then the issue of data management. How do we ensure that we are collecting accurate and efficient data? It's an issue too, because if our auditors are not well trained and if they are not validated, I can assure you that they will be supplying data that are not accurate. We have tried that severally, where we ask auditors, train auditors, to observe the same activity and record their findings. And of course, by the time you look at what in place already, it was totally different, but they observed the same activity. So that could also be an issue. Then resistance from staff, when healthcare workers perceive that using the audit might be punitive, and they may want to resist us, coming to observe them. And of course, this issue of workload. Auditors will tell you that, look, I have so much work. I don't have time for this. This is an additional work. And they may not want to carry out the audit when it is needed most. Then the issue of sustainability, of course, this one is a common problem among our facilities. When we have maybe now World Hand Hygiene Day is approaching, many facilities will now engage in hand hygiene audits, but thereafter the momentum will slow down, and we will not be able to conduct audits regularly. There are many other reasons work distractions can contribute to this. Remember the time series graph we observed previously. This data was collected regularly. Every 3 months, they are collecting this data, they are documenting it, and they are using it for decision making. So how do we address these challenges? First of all, if you want to address the issue of selection bias, you can carry out your audit at different times of the day, and then you try to observe, you inform your auditors to observe the different professional categories. If you observe nurses, also observe doctors, observe physiotherapists. I'm talking about those who come into the ward. Last time we went around in my hospital to just, I think that was last week. I encountered physiotherapists in the ward. They came to do their work, and I observed them. So in the process of providing feedback, I now asked whether they were house officers. They told me they were physiotherapists. That was interesting. 3 of them in the ward. So we can, and of course, you won't know whether they are doctors or other health. So because they were well dressed in their lab coats, and they also carry stethoscope. So that's the case. So if we are observing, we should observe all cadre of healthcare workers and not focus on any particular cadre. Then for the hold-on effects, we want to conduct covert audits. They will not know that we're observing them. And then if we integrate all this into routine IPC practices, or even routine healthcare activity, maybe within a particular ward, it's routine. Somebody, a link nurse, will just walk in and carry out the activity routinely and then leave. People will not even care when that activity is doing. And sometimes if you continue to do audits over a period of time, Healthcare workers will forget. They will even know that that's what you always come to do. So you get your data that is not biased. Then when it comes to this time and resource constraint, we need to get our leadership support. And then the auditors we will select, they should be those who have interest in IPC, so that the passion will be from their heart and not just to join the team because somebody asked them to be part of it. Data management, we need to validate our auditors. And they will also need to utilize tools that are user-friendly, like the hygiene observation form, of course, a user-friendly tool. We train them properly and validate them. Then we'll be very sure that the data we are getting is is uh, is accurate and valid. And not only that, as IPC focus person, we also need to build our capacity. We need to build our capacity to, you know, analyze this data. And not only that, we need to establish, you know, a standard data management procedures so that everyone will be doing the same thing. Therefore, sustainability, where my suggestion is just for us to, to integrate audit into our routine IPC practices. And then we'll continue to provide ongoing training and support. And not only that, we use the result of our audit to demonstrate impact. For instance, now, like I said, if we collect this data over time, we're able to demonstrate trend that look, see what is happening. Our hand hygiene is improving based on this or the see the data. I think that will encourage both our hospital management and even the healthcare workers to do more. Of course, if things are going the other way around, we also show them the data that look, we are not just saying this, look, this is the facts, see what we observe. So it's very, very important we integrate audit into our routine IPC practices. I know that this is one area that we are weak or across board. And that is this aspect of audit. I think that should fall under the core components of monitoring and evaluation and feedback for IPC. We often score very low in that particular component. But I know that we are making progress as a nation, and some facilities are really leading the way in this. And I know that we'll get it right in our country as well. So, what are some key guidelines for auditors? Just we need to share this with our auditors. There could be more. We talk about audits should not focus on only one category of healthcare workers. It should cut across. We should cover all professional categories. And then to make our work effective, we need to assign a validated auditor to a particular service delivery area. Maybe assign one, for instance, we train six in one of the federal hospitals. In my facility, we train eight. So we assign each person to a particular ward. This is your ward, cover this ward. Of course, before we do that, we made sure that they understood 5 months for hand hygiene. They knew how to enter the data on the forms. In fact, they were validated, you know. Then we need to carry out audit at different times of the day to avoid selection bias. And of course, when we target busy periods, those are the best time we to make hand hygiene observation. I remember an experience recently too, not in my hospital, in another hospital. We went to the wards when the ward rounds and they not have not started their I think their afternoon rounds, or when they I don't know what they normally do, but that period when nurses do their own activities and maybe they exchange the their duties. So we went in between that time when ward round has ended and when the nurses were not yet doing that. So we could not see workers busy, providing care to patients, and it was difficult to really record opportunities. So we should target those busy periods. We know our hospitals better, and we know when to get the doctors, the wards, and the nurses in the wards doing their work. And then it's better to record fewer moments accurately than many moments inaccurately. So important that when we go, we should not just aim to meet the target of 200 opportunities within a particular season, and then we'll be recording nonsense. So we need to see those opportunities that we recognize and we knew the action that was taken after that opportunity, we record them rather than rush it. And then in the end, the data we are collecting will not make any sense. So it's very important we advise our auditors so that if we give an auditor a target of maybe 10 opportunities in a week or 20 in a week, he should not rush it. He or she should not rush it. You just take the time, observe accurately, and document accurately. Then, if there is an observance of any unsafe practice, for instance, you see a healthcare worker using the same glove to attend to multiple patients, rather than just say that, okay, I came to do all that, and let me see what he will do. It's better to interrupt that process and provide education to that particular healthcare worker so that the worker will not continue to spread infections within that particular ward. So it's important we note this. And then it should be done professionally and constructively too, so that the healthcare worker will not feel offended or embarrassed or become resistant, but we'll do it professionally. We've done that a lot, and we observe that workers who were clearly, engaged in unsafe practices, ignorantly though, they had to like agree with us that they were doing the wrong thing and that they will improve on their behavior. So it's very important to provide that kind of immediate performance feedback when we observe that uh, when we observe any unsafe practice. And sometimes, if you are dealing with very senior colleagues, talking about maybe you're in a hospital setting and the offender is a very senior consultant, it becomes quite a challenge for a very junior staff to go and talk to a senior consultant. I don't know how we are going to navigate that, but for those who are, if you have a senior member in your team, that is better for that senior member to engage with the other senior person, because I think we have that cultural issue here where a junior staff cannot, talk freely to a senior staff, especially when it comes to pointing something that may not be too correct. So I think at this point, I basically have gone through what this subject is all about. The next 5 slides or so are really about some of the things we will be seeing in the world, because this we are not really meant to start talking about what we are going to be doing in the world, how to collect the data. Those who have been exposed to the training, the various training programs organized by the NCDC or the CCAPS um, programs, you must have come across this. So, but we will still mention this one so that we remind ourselves about this concept for observing hand hygiene, indication, and opportunity. So we start by looking at healthcare activity once again. Healthcare activity is a succession of tasks during which the healthcare worker's hands touch different types of surfaces. So you can touch the patient, you can touch his body fluids, you can touch objects and surfaces located within the patient's surroundings and within the healthcare environment. And each contact is a potential source of contamination for the healthcare workers. And that is why whenever there is a contact, that creates a risk of transmission of infection. So that will now lead us to the indication, which is the reason why hand hygiene is necessary at that particular moment. The justification there is that there's a risk of germ transmission from one surface to another. For instance, you ask yourself, oh, why must I perform hand hygiene? Well, it's because I want to touch this patient. I want to touch this patient. I don't want to transfer pathogens on my hands to the patient. That's an indication for hand hygiene. The reason why hand hygiene is necessary. I don't want to do that. So contact with any surface will generate that justification for hand hygiene. Any contact will always do that. Then what is opportunity? Opportunity is the moment when hand hygiene action is necessary during the healthcare activity to interrupt germ transmission by hand. So the major difference between opportunity and indication is that when you talk about opportunity, the concept of interrupting germ transmission by hands come into play. So if within that space, within that patient's zone, within that sequence of care activities, there's no need to interrupt transmission of infection by the hand from one surface to another. Then no opportunity has been created. So whenever there's an opportunity, there should be a corresponding hand hygiene action. Because the opportunity is that you need to interrupt transmission, germ transmission or pathogen transmission by the hand. So therefore, there must be an hand hygiene action. That hand hygiene action could be hand rubbing with an alcohol-based hand rub or hand washing with soap and running water. Of course, multiple indications can come together to create a single opportunity. In that case, for that opportunity, one hand hygiene action will suffice to break the transmission of pathogens from one surface to the other. So looking at the next slide, you can see the form. This form is available on the WHO website, and we should all download the form and read the instructions. It's not a very difficult form to understand. Just read the instructions on the back of the form. Okay, sorry, we used to print it then. So, but you can have it's about 4 pages. I think on the second page, you'll find the instruction. Either second or third, you find the instructions on how to complete this observation. It's a very, very important form that is used to document what we observe during hand hygiene compliance audits. So when you look at, we talked about this. Now, this is just part of the form that that was screenshot and placed there. So you can see OPP. Now, the other aspect of the form, which I expect us to look into. Sorry, I'm going back to it. You have the intro of the form. You have the facility. You have the service area. You have the ward. You have the departments. This is a WHO form, so you see country there. So we don't need country. I'm sure. I think we should modify our own. It has been modified actually. It's available on the NCDC Red Cap platform. So instead of country, you see states. I said then the period you are doing observation, the date of observation, the time you start the session, and the time the session is ended, and then the duration of each session. The session number. Now each session is meant to last between 10 to 30 minutes, average 20 minutes for each session you observe. You stay there and observe healthcare activities for up to 20 seconds and record whatever you observe. Then the observer initials, you put the observer initials, who is, it's not very, very clear there, but those of us who are familiar with the form, it's self-explanatory, it's easy to fill. And if you download this form and you have any challenge, you can call your IPC focal person, or you can call any one of us from any part of the country. We will respond to you. We will gladly, offer some guidance on how to fill the form. Then you also have, I don't know if it's very clear from your devices. You have okay. I think this is here. Oh no. Okay, you have the professional category that will tell you who are you observing. Then you also have the code for the professional category. Then you have the number that is indicated by a single stroke or a tally mark to suggest how many of such professionals were observed. So there are professional codes I don't think we have adopted any nationally, accepted code. Maybe we'll seek for direction from the NCDC, um, which number should be assigned to doctors, nurses, and then other professional categories. But the form itself, there's a suggestion on the instruction page as to what code should be assigned to nurses, to doctors, physiotherapists, auxiliaries, and others. So each column where you have, let me go back, let me go to the next slide. So on each column where you have OPP, OP is for opportunity, where you have OPP, indication, and hand hygiene action. There are about eight of such grids in yeah, okay, there are 8 rules. Sorry, there are 8 rules in each column. So you have the opportunity, you have the indications, and then you have the hand hygiene action. So whenever an opportunity is observed, there must be a corresponding hand hygiene action. And that hand hygiene action, of course, could be HR for hand rub, HW for hand wash. Then you have mist. Then you have another small circle there with gloves written. Now you only check that where you have gloves when there was a missed opportunity. Then for the indication, let me say you have a staff or you're observing a healthcare worker who is going to provide care to a patient. You are watching to see what he or she does before taking vital signs. Now, if the healthcare worker performs hand hygiene by hand rubbing with alcohol-based hand rub, or maybe use soap and water, running water in any nearby sink before that procedure, you just check, you just put an X where you have BFPH, that's before patient. You just put an X there, and then you now check the corresponding hand hygiene action that was taken. The same thing applies to the other indications before aseptic procedure, after exposure to blood or to body fluids, and animal say blood and body fluids. After part means after touching a patient. Then after PSURR is after touching the patient's surroundings. So those are the indications. So when you are observing a healthcare worker and you see any of this, maybe he has just manipulated, an IV line, an IV access line. That is a potential exposure to blood and body fluid. You now watch what he will do next. If he walks away and didn't perform an hygiene, you just check on the zero on the missed circle. You just put an X on missed. If he was going to set a line, of course you'll be watching. Before he set that line, did he perform hand hygiene either by hand rubbing or washing his hands with soap and running water? If he did, of course you check that yes, the right action was taken. If he did not, you check missed. Now, if the person missed it and was wearing gloves, then you also checked, um, the smaller circle with gloves. Sometimes you could have a coincidence of multiple indications. The slide you are seeing there just showing us an example of that, where a healthcare worker is moving from one patient, maybe after touching the patient, is moving to another patient to perform another procedure. To perform another procedure. So in that case, it just requires one hand hygiene action to cover for the two. One hand hygiene action will effectively interrupt the transmission of pathogens. So in this case, you will check two of them. You will check after touching patient, that is AFT, PAT, you check that one. And then you also check BFPAT, that is before patient. You check the two. And then you check the hand hygiene action that was taken. If it was and rubbing with an alcohol-based hand sanitizer, you also check it. If it was mist, you will check mist. If he was wearing gloves and missed performing hand hygiene, you also check gloves. Now, this one is very key because in a study we did, we also found out that that glove was associated with missed hand hygiene action following an opportunity to perform hand hygiene. So it's very, very important we collect the data accurately because it's going to guide us when we are designing our interventions. So the next slide is just giving us an example where you could have coincidence of indications, multiple coincidence of indications. But it's often said that after patient surroundings and after touching patients should not be considered together. They can never coincide because it doesn't even make sense. So if your auditors go to the ward and one of them comes with something like this, of course, you will have to delete that. You won't accept that particular data. We saw that a lot during some of the trainings we conducted recently, where we asked our healthcare workers to document what they observe, and you could still see this. So of course, in that case, you have to discard any data that has after patient and after patient surrounding together. Not just discard that one. Don't take it. And of course, if the healthcare worker was careful enough to take down a note as to why such an observation was made, then the team could discuss it and then come up with what should actually be the right thing. Otherwise, I would recommend that you discard it. Again, so when we are doing this observation, I've mentioned that we must detect at least one indication to count an opportunity. Though multiple indications can occur to determine one opportunity, but for every opportunity, there must be at least one indication before you can say there's an opportunity to interrupt transmission of pathogens from one surface to another. And the hand hygiene action should correspond to the counted opportunity. So in the end, after collecting the data, if you counted maybe 30 opportunities, you should also count um, 30 hand hygiene actions. Of course, you know that the hand hygiene actions will be different. It could be hand rubbing, it could be hand washing, it could be mist. Which of them, whichever it is, but you should be able to count the same number of hand hygiene actions. Then, of course, when you want to now calculate your compliance rate, you will now go for the correct action taken divided by the total opportunity to get your positive hand hygiene compliance. The hand hygiene action is performed either by hand rubbing or hand washing. If it is not performed when indicated, you must record it as missed. It must be recorded as missed. Now, you can see that whatever you see on this slide was taken, is taken verbatim from the WHO training slide, this particular slide. You see, the emphasis is not on whether all the surfaces of the hands were covered with the alcohol base, and of course, you may not be able to even see that. Is whether it was done when indicated. If it wasn't, was missed. If it was done, but you feel that maybe it wasn't done well, no problem. Still record it as an action taken. But then provide that feedback to the healthcare worker to educate the healthcare worker to perform hand hygiene properly. An observed hand hygiene action not corresponding to an actual indication should not be recorded. Like we said, if you see someone maybe moving along the corridors and perform hand hygiene and then go ahead to be discussing with his colleagues, that should not be recorded. Even if the person is in the ward, he perform hand hygiene and you are observing the person, he didn't go to touch a patient. He just ended up maybe discussing with the nurses and then asking one or two questions and then leaving the ward. That should not be recorded as well because there was no indication as per the 5 moments. There was no before patient touching patient. There was no aseptic procedure. It did not expose itself to body fluid. So there was no corresponding opportunity. There was no need for him to break any or interrupt any transmission infection. So there's no point in recording that. You allow it go and watch. So until there is an indication and a corresponding opportunity, of course, with the action taken, you don't have to record anything. So how do we calculate compliance? Compliance is the performed hand hygiene actions divided by the required hand hygiene action, which is the opportunities, times 100. You now get your hand hygiene compliance rate. On the hand hygiene observation form, there's another form that provides a kind of summary of all the observations. So once you impute all the data that have been collected, you can now summarize and calculate your compliance. And the beauty of that form is that if you use that form to record all the data collected, you can easily calculate compliance, the number of hand rubbing, the number of hand washing. It's all clear with that form. So it's very easy. And I encourage all our practitioners to go and check that form out. Download the full form. It's 4 pages, and then study it for yourself. So what are our key takeaways? That hand hygiene audit is a healthcare quality improvement activity. We must always have that at the back of our mind. That's the overarching goal. We want to improve the quality of our healthcare, which IPC is an integral component. And hand hygiene audits requires proper planning to succeed. Like I said, it's not one of those. It's not a low-hanging fruit. It's a task that requires proper planning and thoughtfulness for us to execute and then implement it successfully. And it must be carried out by trained and validated hand hygiene auditors. I want to say this to my colleagues that just attended a session and you were exposed to the hand hygiene videos, and then say, oh, I've understood this, I can go. You are not a validated auditor yet. To be a validated auditor, you must have, conducted that same exercise with another validated auditor. And then both of you observe the same activities, actually multiple times, and record the same thing. Because that's the only way to be sure that you have understood the concept. And there's this group, I think that it should be an Australian group. They even recommended that hand hygiene auditors should be validated at least annually. There are some conditions listed for them to be, to be certified, validated. So it's very, very important we take note of this. Anybody cannot go to the world that is going to conduct hand hygiene audits. They will bring you results that is inaccurate, that cannot be used to make any meaningful decision. And when we get our results, it should guide our decisions about hand hygiene improvement. Like most of the facilities that are undergoing hand hygiene audits now, what is the purpose? We don't just want the numbers. We want to use the numbers and challenge ourselves to improve. One of our colleagues shared, very poor and poor results from hand hygiene audits. So that is good. At least we know that we are not doing well. That's just from a section of the hospital anyway. We know we are not doing well here. That is good. Don't feel bad about it. We are going to work on that and take another measurement then we'll know that we are either succeeding or not. And then you guide a lot of other things we do to ensure that we improve our practices. And mind you, hand hygiene is a behavior. And to change behavior takes time because there are a lot of other factors that influences people's behavior. So we just need to work, and then I'm very, very sure that we will get it right. So I think this brings me to the end of the presentation. I've been talking for the past, I don't know how many minutes now. So that's our bibliography. So if you want to read further, you can consult these documents. Thank you very much for your attention.
Thank you.
So at this time, we'll be ready to.
Thank you, sir.
Thank you,
Thank you, sir.
sir.
Thank you so much, sir.
Thank you so much.
Thank you, sir.
Thank you.
Thank you.
IPC practitioner, the call.
Thank
I'm very,
you.
very sorry. Thank you so much.
Thank you.
sir.
I'll wait your comments and questions.
Thank you so much, Dr. Ogbune, for such a very timely, insightful, and beautiful presentation.
Thank you.
Let's appreciate him with our best emoji in the chat box. He has not only highlighted the steps in implementing hand hygiene audits, but he has shown us its importance and also how we can ensure compliance. Personally, for me, one of the aspects of this presentation that stood out for me is that data-driven strategies can lead to measurable improvements in infection prevention. And that's just a beautiful thing. And we've also been able to see clearly that hand hygiene, beyond just being a routine, should be a culture. And audit is one of the best tools that can help us sustain and strengthen that culture across all our healthcare facilities. So at this point, we're opening up to questions, contributions, and reflections. So I'm going to go to the chat box. I'm aware that we do not have so much time on our hand. Okay, so I saw a question earlier. So it said, is the section duration of 10 to 30 minutes for the entire observation of activities, in bracket for 32 opportunities, for one column of 8 or only one activity per opportunity? So I don't know if I got that question very clearly. So let me just read it again. The person said, is the section duration of 30 minutes for the entire observation of activities, in bracket for 32 opportunities, for one column of 8 or only one activity per opportunity, stroke opportunity? Dr. Bune, I don't know if you got the question clearly.
Yeah, I got the question. Thank you very much for that brilliant question. Yeah, that's 10 to 30 minutes, average is 20 minutes, is for a session, an observation session. And during that observation session, you can observe 32 opportunities. That is, if there is activity going on. And then for someone who is proficient in this, he or she can observe 2 or 3 healthcare workers at the same time. It's just for you to know what you are looking at. I give an instance. I have a consultant with maybe 5 resident doctors, all of them standing around a patient. You know what happened during ward round. And he asked one of them to examine the patient. So my eye, I'm focused on that particular one. So before he palpates the abdomen, I didn't see him perform hand hygiene. I've already checked before patient missed. If he did, I've checked before patient hand rubbing. At the same time, I've also observed 3 other resident doctors already holding the bed raised. That one is they have already touched the patient surrounding. So I'm watching them. That for someone who is proficient, so that you don't miss recording the corresponding action. For me, I've already observed 3 of them touching the bed raise, or one of them is holding the drip stand. I've already seen that and I'm watching. Immediately I leave that patient to the next. I watch all the others, the 3 that I saw touching the bed tray, holding the drip stand, and they have all touched the patient environment. So immediately they leave and they go to the next patient, maybe patient they want to see, and they control the activity as if nothing has happened. I've already checked, that is, touch patients around. I've already checked 3 opportunities missed for 3 different doctors, as the case may be. So, but if you have not achieved that level of proficiency, don't try it, because you'll be confused. You will not know who did what and what happened next. So you can just concentrate on one particular healthcare worker, the one that was going to palpate the abdomen. You are watching, he palpates the abdomen, and he gives his report to the consultant. You are just watching. He has not done anything. You are watching. He has already missed before touching the patient. And of course, after finishing that particular activity by maybe palpating the abdomen or doing an auscultation, he has touched the patient. So two indications have already taken place. Two opportunities have been created for hand hygiene. You have already documented that he has missed the first one, that's before patient. You are now watching to see what he will do next. If they now leave that patient, maybe that patient care zone, and move to another patient care zone within the same healthcare environment, you are still watching that particular doctor. He has not done anything, and he starts another procedure. Of course, you document that he has missed after touching patient surroundings. So you just document. But if you perform hand rub after touching that patient, after performing the palpation or sketch, as the case may be, and you perform hand rubbing with an alcohol-based sanitizer, of course you record it that he has taken the right action. You just check where you have HR. So ideally, I just got a situation whereby within that session of maybe 20 minutes, I've observed 5 hand hygiene opportunities and 5 corresponding actions. I've already documented it. And it could be more. So it's not restricted. It just depends on your proficiency. And you will recall that I said that it's better to record fewer moments than to record multiple moments and record what will not be useful. So you can record 32. Yes, if there is intense activity within that session, and you're able to capture all of them accurately. Then let me also say that each column is supposed to serve for a particular professional group. So looking at that column, I can't zoom from your, but if you can zoom from your device, if you zoom it, you will see that if there are 4 columns there actually. If you start the first column for nurses, the professional characteristic is nurses, then you must on that particular column, you cannot observe a doctor and record in that column. It must be for nurses only. So if you dedicate any column to a particular professional category, you must only record that professional category on that column. If at the end of the day you did not fill up all the 8 rows there, of course you can leave the others blank or cross it for that particular session because you did not complete it. I don't make any mistake. So each column is to be dedicated to a particular professional category. I hope that I was able to answer your question. Thank you.
Oh, yes, she has acknowledged that. Thank you, sir, for your response. So while we await other questions, I've shared the feedback form. Thank you so much, Dr. Bonaya. We really, really appreciate your time and for sharing your knowledge with us. Okay, so I've shared the feedback form. We have on the call Dr. Showande, and I understand she wants to make a comment. Dr. Showande, you have the floor now.
Yeah, good afternoon all, and I want to say big thank you to Dr. Bonaya Goswell, where we are not expecting anything less than this. This is very, very timely because May 5th is around the corner and people should actually start thinking about activities to make sure that we move our hand hygiene program forward. And it's not just doing the hand hygiene, it's not just training, it's documenting it. And what is the target? Quality improvement. If we are not doing quality improvement, then we're just wasting our time. We need to be persistent, we need to train and retrain. But we want Dr. Bonaya, he will leave his email address. But what I want to please ask, I noticed at the beginning we had a participant from Cameroon, Baptist Hospital, and I know they are very, very proficient with hand hygiene. I don't know if they have any experience to share or any questions or comments, because it would be nice. Yeah, we are Nigerians, but we want to know what's going on in Cameroon next door to us. Thank you. Thank you very much again, Dr. Bonaya, and thank you all for making out time to be part of this. And we look forward to very useful, impactful May 5th celebration that we can document. Thank you. Over and out.
Okay, thank you so much, Dr. Showande. Like I said earlier, we have the feedback form. I've shared it in the chat box. So please do well to fill the feedback form. Dr. Obune has also shared his email in case you have questions. And then, in addition to what Dr. Showande has said, I will really be interested and seek that IPC practitioners share with NSIC what they are doing on the World Hand Hygiene Day. You can share with us via email so we can put it up on our social media platform. We really love to know what's going on in our healthcare facilities, interesting events coming up on the 5th of May. And like I said earlier, the theme is, it might be gloves, it's always hand hygiene. Thank you so much. I don't know if we will have more questions before we draw the curtain. Do we have comments from our colleagues from Cameroon?
Cameroon, because I know their
And
echo
Togo.
is actually hand hygiene. That's the label. Nice, at least for this session, to have them share their experience if they are still on.
We also have a colleague from Togo, in case he wants to make any comments or contribution. Okay. All right, go ahead, Ma.
Okay, hi everyone. Good afternoon. I'm Joyce from Cameroon. Also take part in the hand hygiene eco year in Cameroon. We have been doing some work so far. We're under the Baptist Hospital. The Baptist Hospital is one that's piloting the hand hygiene eco. I'm doing so much work sensitizing healthcare workers, paying more emphasis on cleaners, because at times we ignore cleaners, but they too help in transmitting bacterial microorganisms in the wards. So it was really an interesting session. It was really insightful. Thank you, Dr. Bonaya, and thanks to the West African Hand Hygiene. Thank you to the West African, it's Nigerian ECHO, right?
Yeah, Nigerian Society for Infection Control, yes.
Yes, Nigerian Society for
Infection
Control.
Control.
Yeah. Thank you for organizing it. I really enjoyed the session.
Thank you so much for that comment. We're really happy to be aware of what's going on in Cameroon.
I'm working in the reference hospital here in Douala, Cameroon.
Oh, that's great.
I can senior hospital.
All right. Thank you so much, Dr. Joyce. Thank you so much. So someone is asking, are we going to get the slides and the recorded section? Yes, you will get it. So now I'm going to share a link, and we would love you to use that link to give us your email address so that you can get the recorded section. And then for some of us that might be wondering, I would love to be a registered member of this society. In NSIC, we're committed to fostering excellence in IPC through collaboration, education, and advocacy. And so that's why you see that part of the things that we do, we have this monthly section where we kind of build our capacity in some of the subjects in IPC. Have look through these contributions and then share our knowledge and expertise. So we look forward to having you every last Thursday of the month. It's a monthly section. So for some of us that might want to register, we'll also use this link to give us your details, your email address. And then if you have questions, you want to know how to get more information about NSIC, you can use this email to reach out to us, nsicnigeria@gmail.com. When you become a registered member of NSIC, interestingly, it also helps you to become a member of the international body, that's Infection Control African Network. And one of the advantages is that your registration covers for both NSIC and also ICANN. Being a member of a national body gives you a 75% discount for your registration in ICANN. So I think it's very interesting for you to join this national body. why we move forward IPC, not just in Nigeria, but also globally. It's been quite an interesting time with each and every one of us. You're going to get the recorded section. Thank you so much, Dr. Ogbonnaya. We really appreciate your time and also sharing your expertise.
One more thing, Amaka.
Okay.
Yeah, and this is opportunity to even publish your work. If you can do this research, you do your baseline, and then you follow up, you monitor, and you are improving, your IPC intervention is working, you can publish it at any conference. It could be the Nigeria conference, the ICANN conference, and there is a global body that is ICPC coming up very soon. So this is an opportunity for you to be known globally. We're starting with hand hygiene, but it can be some other things. But we want to see you grow and grow and grow. Thank you, and I wish you all the very best.
Thank you, ma.
Thank you so much. So at this
Thank
we will
Thank you, ma'am.
the curtains.
Thank you so much.
If you have any,
Plus, give us your feedback, and please, if you have any topic that you feel you want, you can also suggest to us. We are open to suggestions. As we work to make IPC better in Nigeria, with the support of our NCDC. Thank you, and God bless.
Thank you, ma'am. Please, even though my hands is not up,
Thank you.
I want to ask a question.
all
I'm
right.
trying to use the raise hand emoji, but it's not just coming up. I don't know why. I am nurse Rahila Haluta from University of Jos Teaching Hospital, Plateau State. What I want to know is about this. The lecture we just finished. Actually, I came in a little late, but I was able to get some things. What I don't understand, when I am there, at some point, I think when I was being taught in an IPC training class, that once I am there for an opportunity or observing action, if I just, that individual whom I'm there to observe, I should really concentrate on that individual and until it's finished. Even if by the side there are other people that are doing other things that might not be right, health workers, like the way he said about these other doctors, but let's say I'm focusing on nurses now, or two nurses, and there three doctors just arrived and are doing the same thing. So do you think it's really ideal that I should just join this 5 group of people and be watching the indications and opportunity for hand hygiene? I mean, an indication for hand and hygiene and the opportunity they missed, things like that. That's just what I want to know.
Okay, am I permitted? Can I just respond to
Yes,
that
please go
quickly?
ahead, sir.
Okay, like I said before, if you're a starter, the advice is stick to one healthcare worker. As you improve in your proficiency to observe, you can handle 2, but it's advised not to handle more than 3, because you need to process all those information and be sure you are observing what happens next. So the person that gave you that advice
Exactly.
was right in the way, because you were a beginner. So they were telling you that please just focus on one healthcare worker. But if you keep doing it, the example I gave you, I'm using myself as someone who has been doing this thing for several years. So it becomes easier for me to observe multiple healthcare workers without so much mental stress. Yes. So, but if you're a starter, stick to one. As you improve, you can add 2, 3 years. They don't go more than 3. Thank you.
Okay, sir. Thank you. Thank you so much. Thank you. You have answered my questions. Thank you, sir.
All right. I don't know if we
I'm
have
okay.
any other question. Any other question? before we draw the curtains. So to everyone, like some people are dropping their emails in the chat box. Please, we might not be able to capture every email shared yet. So please use this link that I just put in the chat box now to fill up the form. Let's have your email. So you're in our database. We can share recorded sections with you, and then every relevant information in IPC, we share it with you. Please, let's use this link. Thank you so much. So at this point, I want to say thank you to everyone who made this program a success. Thank you to our speaker, and thank you to everyone who participated today. We are looking forward to a wonderful and an impactful World Hand Hygiene Day next month, 5th of May. All the best to everyone, and thank you. Goodbye.
Bye.
Thank you. Goodbye.
Thank you.
Bye-bye.
Thank you. Bye.
Bye-bye.
Bye.
Bye.